So Rashmi, thanks for your kind words. And first of all, I would really like to thank the organizers. I can only appreciate what a crushing disappointment it must have been last year to absolutely cancel at the last minute. And then in the face of the pandemic, to open up the dialogue and have these sessions has been a really wonderful achievement. So thank you and congratulations. For the talk, I've taken two liberties. One is I don't think the word failure exists in the pediatric oncology lexicon, so I think challenges is more appropriate. And as Lakshmi has alluded already, sorry, Rashmi has alluded already, I'd like to focus on the collaborative experiences in India over the last few years. Now, the challenges are fairly obvious. The outcomes in the West are now more than 90% for children with acute lymphoblastic leukemia, while in India, even at our best centers using very similar protocols, as you can see here, is more than 20% behind. And what's quite sobering is that just the treatment-related mortality almost bridges this gap. And what have we learned from the West? So success is attributed to collaborative clinical trials, recruiting large number of patients over quite a number of years. And these are multi-center trials. And one advantage here is that as any center develops good practice, this can be rapidly adopted by all centers as standard of care. And the second is that these protocols have primarily used risk stratified therapy, which de-intensifies as therapy for patients deemed to be at low risk of relapse and thus decreasing toxicity. Well, in India, with the exception of the MCP 841 protocol, by and large, there have been single center studies which have recruited small numbers of patients, again, over a large period of time, and they have been all-purpose intensive therapies. So all patients have received intensive therapy and there's been no risk stratification. So the first attempt was to really form this collaborative group and with the idea that in the least we could assure our patients that didn't matter where they went to, they would get the same standard of care. So in 2012 to 2013, we set up a collaborative working group which developed a consensus collaborative protocol. And then until about 2016, we piloted this study along with standardizing the different components of the risk stratification and data collection. And in 2017, obtained funding for a fully randomized clinical trial. This risk stratification is based on fairly standard criteria. The NCI standard risk and high risk form the standard risk and intermediate risk. And in the patients in BCP ALL are then classified into high risk based on cytogenetics and if they have a prednisolone poor response at diagnosis, and post induction, if their MRD is higher than 10 to the power minus 4 in the standard risk or intermediate risk, they join the high risk. No risk stratification for TLL. And really at the bottom shows you the differences in treatment where the high risk and T get a full intensity treatment. The standard risk patients are not exposed to anthracyclines in induction and no cyclophosphamide and cytarabine during consolidation or high dose methotrexate. And the intermediate risk group fall in between. Now, as we were talking about how each center can contribute different aspects to standardization of care, the fact that all patients were being treated on the same protocol allowed the different centers to explore optimization of flow cytometry, minimal residual disease, genetic testing, and how to deliver high dose therapy. And this was easily incorporated into all centers as standards of care because we were all using the same protocol. Now, the key toxicity, because we talked, one of the big issues is about treatment-related mortality. The key toxicity in any of these protocols is infection or sepsis due to the periods of neutropenia. And so this graph taken from the current clinical trial shows you the rate of sepsis, more than grade 3, during induction, consolidation, and the different phases of treatment. And this is on this axis shows you the percentage. If you concentrate on the blue line, so these are the younger patients, less than 10, who are standard risk. And these on the red line on the top are the younger patients who are classified as intermediate risk. And the main difference between these two groups at induction is 2 doses of anthracycline. You can see how in the younger children, just adding two more doses of anthracycline significantly increases the toxicity. And you can see that again in delayed intensification, where all patients get the same drugs, all exposed to anthracyclines. It's the younger children who have the same toxicity, have the increase, sorry, have the highest number of toxicity. And you can see the same thing again when in the cyclophosphamide cytarabine arm here, where the younger children and generally all the children exposed to cyclophosphamide cytarabine have higher levels of sepsis, while the standard risk patients not exposed to cyclophosphamide cytarabine have significantly lower incidence of sepsis. So decreased intensity of treatment does decrease toxicity. And at the Tata Medical Center, using our electronic patient billing system, we were able to look at the costs of therapy. And so just to sort of, very look at it on an overview, the cost of a high-risk patient is almost double that of a standard risk patient. So if you don't risk intensify, then you're forced to treat your patients either as intermediate risk or high risk, with 24% or 84% increase in costs, and more than 50% of that cost is actually going to be in managing toxicities. So reassuringly, like with the other collaborative groups, over time, as we grew more experienced and we shared our knowledge, we saw a fall in the treatment-related mortality. It's too early to talk about relapse rates because the trial is not yet mature yet, but we do have data from the pre-trial cohort in terms of outcomes, and you can see them here. So you can see that the outcomes in standard risk, high risk, and TALL are probably satisfactory, but we have a problem with the group in the intermediate risk group. And I have to say that one of the problems with the pretrial cohort is we were still finalizing everything. And for example, the genetic risk stratification, we know the genetic data of 60% of the patients, unlike in the trial cohort where we know have this data about 90% of patients. But nevertheless, we began to look at this problem in more detail, and I would like to discuss with you 4 different aspects that we found. The first is the genetic risk stratification, which has already been discussed in great detail by earlier speakers. So if you look at the icicle strategy, it depends on a 3-probe FISH strategy to split the low risk from the high risk, and anybody else not identified this falls into this intermediate risk group. And this shows you a karyotype which is high APET diploid, considered to be low risk. We can detect it either by karyotype or by flow ploidy, which some of the centers have now published their data on, or by an interface FISH, where you can see this is the ETP6 RUNX1 FISH probe, and you can see the 2 signals of 12 and the 4 signals of 21, and you can see the 4 copies of 21. Now, this particular patient was standard risk, but at the end of induction, the MRD was 2.3%. When it was intensified therapy, and in the consolidation, there was a satisfactory negative MRD result by flow. By the end of 1 year after stopping treatment, it relapsed. And Pratik has already shown you that with the genetic risk stratification of ALL requires now copy number alterations, mutations, and the detective cryptic fusions, of which the Philadelphia-like group is a classical example, also discussed by Shekhar Krishnan earlier on. So in this patient, further investigation showed this patient had an Icarus deletion, which you can see here. And the patient had a JAK2 mutation and had a cryptic PAR2 fusion. So this is actually a patient who's Philadelphia-like ALL. Okay, so this is not a low-risk cytogenetics, but a high-risk cytogenetics. So one of the challenges going forward is how to improve our genetic classification at all other centers for all the patients. The second area that we identified, and this is a talk given by Dr. Gota earlier on, and Dr. Sidhu is going to talk about this later on, is the quality of drugs, and particularly the quality of the drug that we are most worried about is asparagines. If you remember, the standard risk patients don't get anthracycline, so they're primarily dependent on vincristine steroids and asparagines. And in India, there are about 15 or so generic asparaginases available. You can see the table on the right. And if you look at this gel diagram, I promise you it's the only gel I'm going to show you. This is the Medac E. coli asparaginase. These are the bands that you would expect to see in asparaginase, and these are the generic asparaginases that we investigated. And you can see these lower bands and upper bands, and these are all impurities. So these impurities will increase toxicity, affect the bioavailability, and make these drugs probably unsuitable for commercial use. We went on to investigate a number of these asparaginases, So based on the data from MEDAC, the dose recommended in icicle was 10,000 international units of E. coli asparaginase given every 72 hours to get good trough levels. But you can see with this one, even at 48 hours, a significant number of patients were not achieving good levels. But with leukogenase, and certainly not at 72 hours, but the majority of patients at 48 hours were getting good levels, which forced us to change the scheduling to every 48 hours and introduce therapeutic drug monitoring while we wait better asparaginases coming into the market. The second area that we were worried about is how good was our MRD detection, because if the MRD was not sensitive enough, then patients who should have been stratified to high risk may have been incorrectly classified to low risk. So this is just to show you two comparators. Up on the top is data from our center. Below is the Tata Memorial Center, which is the nodal center for flow cytometry-based MRD in the icicle network. And reassuringly, you can see over time, the MRD positivity rate has gone up. But there is a discrepancy between these two centers in their MRD rate. And they're still lower than what we expected for 35 to 40%, suggesting that we are missing some patients, and this technique is not standardized between the centers. In Kolkata, we also do IGTCR for select patients, which is integrated into the European MRD network. And I just want to show you three examples. So this patient, if you look at the black, is a flow cytometry classified as high risk at the end of induction and reassuringly negative. IGTCR is usually, we usually use two markers. And you can see one marker is also negative. But the second marker here, you can see is strikes positive and starts rising. And you can predict pretty much what happened after that. The patient relapsed. And at the moment, we have been able to salvage with experimental therapy and blinatumomab. Then you see the second one with flow cytometry. This would have been as low risk, but IGTR identified this patient as high risk. But this patient reassuringly responded to more intensive therapy. And then you have this patient who's currently on treatment where flow would allow us to sleep at night, but IGTR would keep us awake because this is a steadily rising MRD titer. Flow is cheap and rapid, but the obvious problems are they are subjective. One of the questions raised to Prashant as well is, how do you standardize this across all laboratories? This is very difficult to standardize. IGTR is objective, can be standardized, but is expensive and time consuming. The fourth area we looked at was the issue of maintenance therapy. So this is the longest period of therapy. Patients receive 6 mercaptopurine daily for 104 weeks. And the dose has to be titrated to the level of toxicity measured as a surrogate with the absolute neutrophil count. How important is this? Well, there's data from the NOFO, which you can see on the left, which is if the mean neutrophil count is above 2 during the period of maintenance, the relapse rate almost doubles. We've looked at this in our own cohort of patients at Tata Medical Center, where this is from the pre-trial cohort, where patients have completed treatment. And this is a Bayesian calculation, the increase of hazard ratio of relapse on the left, and the number of weeks of 6 mercaptopurine here. And we've classified this where we think the patients received drug to the level of tolerance and where we think the drugs were not given to the level of tolerance. And you can see there's a significant increase of relapse if 6 mercaptopurine is not optimized. How do we tackle this? Tushar Mungle is going to talk more about the strategies that we're adopting tomorrow. The issue of relapse then, because we still have a proportion of patients to relapse, and how do we treat them? The current view is it's expensive, it's toxic. So we modified an existing protocol by adding bortezomib. That's a drug that's available easily in India. And we reduced the high dose cytarabine dose. And we found that the outcomes, both in MRD and outcomes in survival, were quite satisfactory, especially for the patients we classify as probably curable, which are the late relapses. But we learned two things while we were doing this. One is that in the patients who should be transplanted to hold their remission, more than half could not be transplanted primarily due to the lack of resources. And in this group of patients you see over here, the patients who refused relapse treatment, and a good proportion of them probably fell into this group, which is a group of patients who probably are curable if their relapse is properly treated. And again, it was because of lack of resources. So a challenge then is that, when we have patients who have relapsed refractory disease, but possibly can be cured with newer therapies, how do we then provide these resources? So newer things are coming. Dr. Lee alluded to this. Rahul Pawar and Gaurav Nodla and their team, and Rahul has talked about this earlier. One is about indigenization of the CAR T approach. We have a donor program for blinatumomab now, but delivery of the drug is still expensive. At Tata Medical Center, we have a high throughput drug discovery system where we can identify drugs that are currently available on the market, like bortezomib and venetoclax. And you can see that the B cell population is sensitive to that. So is the T cell. We can also have been identifying TLL patients who are sensitive to dasatinib to be able to offer this to patients who are either high MRD or relapsed or refractory. So concluding my talk then, that the success and challenges are the same. I think I've shown to you how the collaborative networks are improving, how things are done, but the challenges will be how to extend these collaborative networks to all other centers and develop hubs where we have properly standardized techniques and tests, including therapeutic drug monitoring, and build decision support tools to help physicians optimize treatment during maintenance, and then extend this treatment of ALL to the older age group, because we know that the pediatric approach works even for patients above the age of 18. Some centers can only treat to the age of 12. So that we can start availing of these things, which is the drug discovery approach and the indigenous CARs and other drugs that are being developed. So it remains me to thank the funding organizations who fund the trial, and our approaches, our collaborators who've helped us with some of the data, and Shekhar Krishnan and the clinical research team, unit team at Kolkata, who produced all this data, and of course, all the collaborators, the icicle network, without which none of this would have been possible. Thank you.